Hi, everyone, and thank you all so much for joining us for today's webinar, The Changing Landscape of Headache Management. My name is Melissa Wilson. I'm the Events Director for Visual DX. Today's webinar will discuss the latest therapies in migraine management. There are new acute and preventive medications that have been approved by the FDA and allow for broader treatment options for migraine patients. Dr. Raisa Villanueva will discuss the treatment options and how they can be used in your practice. Before we get started, I'd like to share a few housekeeping notes. This webinar is being recorded and will be shared with all the registrants. We encourage questions from the audience, so please submit your questions in the Q&A box and we'll get to as many as we can once the lecture is complete. Following the clinical presentation, we'll test your skills with a Kahoot quiz, awarding a prize to the winner, a $100 Amazon gift card. So you'll want to have that app downloaded. That's Kahoot, K-A-H-O-O-T. It's free on the Apple Store and on Google Play. We also ask that you please take our brief survey at the end. I'd like to introduce our presenter today, Dr. Raisa Villanueva. Dr. Villanueva is the Associate Chair of Ambulatory Operations in the Department of Neurology at the University of Rochester Medical Center. As Division Chief of the Headache Center at URMC, she has extensive experience in the care of broad range headache patients, including migraine, post-traumatic headaches, facial pain, and trigeminal autonomic cephalalgias. She is board certified in headache medicine and neurology. Now to get started, I will turn it over to Dr. Villanueva.
Thank you, and thanks to Visual DX for inviting me to do this presentation. All right, so I am going to talk about, there's a lot of new medications that have come out within the past few years. So it's an exciting time for headache medicine. So I'm glad that there's a bunch of people in the audience who are interested in learning about it. So relevant conflicts of interest to this talk, I actually did use some pictures that were available online from the Wellcome collection. And they are basically done by migraine patients. And a lot of these visual art pictures depict a lot of their auras or their feelings of pain that they experience. So I thought it was really helpful to kind of have that visual art to sort of represent patients. So I have two learning objectives for this presentation. One is to just discuss a general approach to headache management, specifically looking at primary headache disorders. So that includes how to take a history, talking about lifestyle modifications, in addition to treatments like medications and non-medications. I also wanted to educate you specifically about acute and preventive medications that we use in migraines. So the first caveat that I did want to mention is that this presentation really is going to focus on primary headache disorders and not secondary headache disorders. So you really want to upfront when you're meeting a patient and doing their history is rule out any secondary headache disorders. So things to look for in symptoms that may rule out secondary headache disorders are any kind of abnormal neurologic exam, any kind of focal neurologic symptoms that aren't consistent with a typical aura, and we'll go into details about that. If there's any history of fevers, chills, weight loss, things like that also, again, are very important. Probably not a primary headache disorder, any rapid increase in the frequency of the headaches or the characteristics of the headaches that are changing. If there's any worsening of headaches that are postural, so worsening of headaches with standing up or even worsening of headaches with lying down, any symptoms of worsening with exertion, so things like physical activity that tend to worsen the headaches can also be a red flag. New onset headaches in somebody who's age 50 or above also can be alarming, somebody that you probably want to get imaging on. A thunderclap headache, again, is another alarming symptom. Well, basically, patients typically will say it's the worst headache of their life. It pretty much comes on suddenly, acute onset, and kind of rapidly progresses to like a maximal level of pain that is just kind of unbearable. So those, again, would be sort of triggers that you might want to consider doing some imaging. Any history of cancer, again, with a change in their typical headache frequency or a hypercoagulable state, again, looking for potential strokes, would also be another reason where you might think it's actually not just a primary headache disorder, but actually something else that is causing headache. So that's definitely, these are things to keep in mind as red flags when you are doing the history and meeting the patient for the first time. So when we think about the epidemiology, headache is a very common symptom, especially migraines. So migraines in particular are predominantly more affecting women. So in the United States, there's about 18% of women that have migraines and 6% of men. So as you can see, there's definitely a gender difference. It's the second most disabling symptom relative to secondary to back pain. And headache can account for actually over 1/3 of over-the-counter analgesic use in the United States. There are 23 million Americans that have migraines. And I think the other thing to keep in mind is both the direct costs, so money that's being spent in healthcare, whether they're outpatient visits, ED visits, urgent care visits, in order to evaluate headache, but also the indirect cost, which typically would include lost productivity. So patients that are typically missing work or leaving work early, and that's estimated to be at least $13 billion per year that employers wind up losing because of absence at work due to headache. So when you think of migraine, you want to think of it as a continuum of symptoms. So it's not only just that time frame during which a patient experiences the pain, which would be in the red part of the graph. There's actually can be premonitory symptoms, which sometimes patients can be aware of, where they may feel off. They may feel different. They may feel like they have some mood changes, some symptoms that can potentially predict that the headache is coming. Then there's about 30% of patients that experience an aura, a migraine aura, which typically has focal neurologic symptoms that are reversible, and they can last anywhere typically between 30 to 60 minutes. However, there are times when the aura can actually last a lot longer than that. So the aura could certainly be another warning sign or warning symptom to the patients that they have the migraine coming. Then, of course, there's a time of the migraine itself where they can have sensitivity to light, sound, nausea, vomiting, and can be fairly debilitated where they can't focus, they can't eat, they don't really have any appetite, they can have some muscle pain. And then after the headache pain starts to resolve, there also can be a postdrome where they just generally still can't function. They may not be able to go back to work. They just feel kind of tired or sleepy. They just want to kind of rest, maybe even sleep. So when you look at that time frame, it can actually extend for days for some people. So the extent of the continuum can be quite variable, obviously patient to patient, but it's something to keep in mind where the length of time that a patient's life is affected and functioning can be affected can actually be fairly extensive. So when you think about the pathophysiology, research has shown that it's really the trigeminal vascular system where the input from the sensory system is taken up. And you want to think of migraine as a brain or sort of a sensory processing disorder. So they just don't necessarily process the typical sensory inputs the way somebody who doesn't have migraines does. And then there's some modulation of that input by the brain centrally to sort of inhibit or accelerate some of these sensory inputs. So we're going to start with a case, which we're going to run through the entire presentation just to kind of illustrate some examples. So we have Tina, who of course is a woman, because again, women are much more affected in her childbearing age, again, which is kind of a typical migraine patient, 30-year-old right-handed woman who has a history of headaches as a teenager. Again, typical to have kind of a history starting in like teens or late teens and then kind of can progress. So hers also progressively increased over time after her pregnancies with 3 children. What she describes is unilateral throbbing with sensitivity to light, sound, and then photophobia. So how do we take a history? So the important thing is you really want to start to ask about what does the head pain actually feel like? How long does it last? Where is the pain? Does it move anywhere? How severe is the pain is another important thing. So we typically will use a visual analog scale of 1 to 10. Do they have sensitivity to light, sound, nausea, or vomiting? Are they able to function, or are they able to do they have to lie down in a dark room? How is their actual life impacted? What is their quality of life? At the Headache Center, we tend to use some functional questionnaires, which are basically patient sort of self-reported, subjective ways to evaluate how their functioning is impacted by their headaches. There's the MIDAS and then there's the HIT-6. The MIDAS has 5 questions, the HIT-6 has 6 questions, and they can be kind of followed over time based on potentially an intervention to evaluate whether or not, okay, is that intervention working or not? But it does give you some idea how the patient's life is impacted and how their functioning is impacted by their headaches. One of the reasons why we ask about the characteristics of their head pain is because it really allows us to help classify the type of headache that they have. The most common types of headaches are really tension headaches and migraine headaches. And when you think about how to classify them, we really use the International Classification of Headache Disorders version 3, so the ICHD-3, and this is their definition of migraine without aura. Again, migraine without aura is more common than migraine with aura. So you want to have at least 5 attacks. The headaches typically last between 4 to 72 hours untreated. And then they want to have 2 out of these 4 characteristics. So the typical characteristics of a migraine are it's unilateral, it's pulsating pain, it tends to be moderate to severe intensity. So typically, patients, when they have migraines, they really have a hard time functioning. There's aggravation by physical, like routine physical activity. So any 2 of those 4 characteristics typically would fulfill that criteria of migraine. During the headache, you also want to have at least 1. So either nausea or vomiting. Again, nausea is much more common than nausea with the vomiting, or photophobia and phonophobia. Again, very common symptoms. So these are the things that you want to ask about when you're trying to classify, does this patient have migraines or does this patient have tension headaches? So now when we look at tension headaches, again, these are a little bit more common, especially in primary care. And they have at least 10 episodes. So as opposed to migraines where they have at least 5 attacks, tension headaches, they have to qualify by having at least 10 episodes occurring less than 1 day a month, fulfilling the following criteria. So again, they have a time frame of duration of symptoms, so 30 minutes to 7 days, and at least 2 of the following 4 characteristics, so similar. But now this is bilateral, okay, for tension headaches, and it's more of a pressing or tightening. A lot of times people will say, I feel a band-like pressure around my forehead, around my head. So it's bilateral, pressing or tightening. It tends to be mild or moderate, and it's not aggravated by physical activity. So typically for tension headaches, patients are actually able to function. So they can typically work, they can typically go about their usual day. They're just not as debilitated because the pain is milder. They also typically would have, again, based on the classification, both of the following. So there's no nausea or vomiting, and either they have photophobia or phonophobia, but not necessarily both. So again, sort of symptoms that would be milder for the patient. And again, not better accounted for by another diagnosis. So the other third category is the trigeminal autonomic cephalalgias. This is a much rarer condition. We see it more obviously in neurology. It's harder to find, I think, in primary care. They tend to be really distinguishable by being unilateral, but typically you see these prominent autonomic symptoms. So the classic sort of trigeminal autonomic cephalalgia, which we also call TACs, are the cluster headaches, where they have this excruciating pain in one eye, a poker-like pain with droopiness of the eyelid, redness of the eye, runny nose on one side. And the autonomic features are actually fairly prominent that the patient usually can tell you, that these symptoms are present, especially when looking in the mirror. So cluster headaches is probably the most common of the TACs, but there's also paroxysmal hemicranias. And then there's another group called short-lasting unilateral neuralgiform headaches. And then there's hemicrania continua. And I won't be going into detail about these today, but those are things to keep in mind. Again, what the other things that distinguish them is not only the autonomic features, but also the duration of these headaches. These headaches tend to be much shorter than the duration of migraine and tension headaches, lasting sometimes 15 to 30 minutes. And typically they have multiple attacks during the day. So the most important component that you need to do when you're meeting a patient that's presenting with a chief complaint of headaches is really take the time to do the history. As I mentioned, the history and the characteristics of the pain, the location of the pain, those are all important in order to be able for you to be able to classify what type of headache they have. Do they have a migraine? Do they have a tension headache? Or do they have a TAC? When they do denote that they have those characteristics of those headaches, what you want to then delineate is how many headache days, how frequent are their headache days? And typically what we call them monthly migraine days or monthly headache days. So how frequent are they having them? And sometimes this can be difficult to pin patients down to be able to really say, I have 3 headache days a week or 3 headache days a month. But that's important because, again, it helps you decide later on when you do have some kind of intervention with medications or non-medication treatment, is there an improvement with that intervention? You also want to ask, what are they using for acute treatment? and how often is that treatment being used. So I'm using ibuprofen or I'm using Excedrin migraine, and I'm using that every day. So that's important to ask, is how often are they using it? Triggers, are there things that seem to trigger the headaches? And we'll go into that in a little bit. Typical triggers. Do they have an aura? Do they have any kind of warning sign, as we talked about the continuum, that may warn the patient prior to the actual headache pain starting? Do they have a prodrome and postdrome? Do they have any history of head trauma? Obviously any recent falls or recent head trauma, concussions can also trigger an increase in headaches. Do they have a family history? Certainly genetics plays a big role in migraines in particular. Do they have autonomic symptoms? Because again, if they have prominent autonomic symptoms, then you're thinking more about attack. Do they have postural symptoms where you're thinking about idiopathic intracranial hypertension? Or do they have worsening of their headaches with standing up, and you're thinking about spontaneous intracranial hypotension, where they may have a CSF leak? What makes the headache better? What makes the headache worse? For women, do they have any worsening of their headaches during their menses? And that's again another typical scenario where they have longer duration, harder to treat migraines during the menstrual period of the month. Do they have any history of use? That can be important as well and relevant to the history. So we go back to Tina, and Tina when you ask her about her history, she has about 8 monthly migraine days, and she also has 5 other headache days. The triggers that she's identified, and a lot of times migraine patients can tell you what bothers them and what can kind of bring on migraines. For her, it's wine, aged cheese, and lack of sleep and stress. She's been using sumatriptan when you ask her about what is she using for her acute treatment, but she needs to redose it a lot. So she takes one dose, it doesn't work, she takes another dose. She uses sumatriptan about 10 times a month, and she's never been on any daily preventive medication. So key in the history is, as I mentioned, identification of triggers. It's important, really, ideally, to be able to identify, especially food triggers, because you'd want to just avoid those triggers. Weather changes, stress, obviously that's much more difficult to control for patients, but certainly there are some lifestyle changes and lifestyle modifications which can play a fairly large role in the treatment of headaches and migraines. What medications have they tried in the past is another important question to ask in the history. There are a number of different classes of medications, and again, we'll go into detail about that in a little bit, but specifically stating what medications have they tried and what have they failed, what side effects have they had. Other treatments that a lot of patients do tend to use are acupuncture, massage, cognitive behavioral therapy, biofeedback, relaxation training, and then there's some procedures like nerve blocks and Botox. So in the history, which I said was the most important component of me, when you're doing an office visit with a patient in the outpatient setting, you really want to ask about how often they're using their acute medications. You'd be surprised at how many patients will tell you, I've been using Excedrin migraine. And then when you ask them, oh yeah, I'm using it every day. Have they had any emergency room or urgent care visits? Are they going to the emergency room every month in order to get, Toradol, IV, or other kind of medications like opioids? Have they gotten Toradol in the primary care doctor's office? And how often is that occurring? Have they missed days of work? Are they leaving work early? Do they even work for a living? These are all important components because it gives you a much better idea of kind of a more holistic approach to the patient. So lifestyle modifications, we talked a little bit about trigger identification and avoidance. I do like to tell patients and inform them and educate them about what are possible triggers. So sleep, fluid hydration. You always want to ask about lifestyle. Are they eating regular meals? So certainly skipped meals, hunger can also be a trigger for headaches. Are they exercising? Because that can certainly help with sleep. That can be related to stress management. Are they drinking caffeine? And caffeine can help sometimes patients treat the migraines, but it also can be a trigger for migraines as well if there's too much caffeine being drank by patients. And it can also affect sleep. So if they have insomnia and they're drinking coffee, in the evening time, that can also obviously be a lifestyle modification to think about. And then obviously stress is a big role. So trigger identification and avoidance, we've got, these are common triggers that we see. So alcohol, wine, MSG, nitrates, aged cheeses, caffeine, tyramine, and chocolate. Those are all common ones. So the other thing that I wanted to talk about was the ICHD definition for chronic migraine, and that's relevant to sometimes some of the treatments that we'll talk about later. So chronic migraine, you have 15 or more headache days per month for greater than 3 months, and at least 8 of these have some migrainous features. So it's typically like, 8 migraines at least, and then 15 or more headache days. And that's the typical definition for chronic migraine. So we go back to Tina and we talk, what about her acute treatment? The fact that she's taking sumatriptan 50 milligrams and she's needing to redose and she's using it 10 times a month. So what are the goals of acute migraine management? What we want to do, and again, what you want to do is you want to consistently ask this about the patients. You want to ask, does it give them rapid freedom from pain? Does it really kind of take away all of the pain without any return of the pain either later that day or the following day? Are they able to now function as a result of taking that acute medication? Do they need to repeat the dosing? Because they use an acute medication, we don't want them going to the emergency room for additional treatment. We don't want them going to urgent care. And obviously, we also want to have minimal side effects. So these are the sort of different classes of medications that we typically use for acute treatment. So we've got anti-inflammatories, so NSAIDs, and those are both over-the-counter ones and prescription ones. There's antiemetics, triptans, there's DHE, and then there's this new class of medications called gepants, which were recently approved in the last year or so. So acute migraine management, what you want to assess for the patient is how debilitated do they get when they have a migraine? Are the migraines or the headaches for them mild and they can still function? Then you want to think about really some of the over-the-counter or the NSAIDs or things like Excedrin migraine. If they have a much more severe attacks, I would say moderate to severe, you really want to start thinking about triptans, and there are 7 of them. There's also these new class of gepants, which again can be considered for these kind of more moderate to severe types of headaches, types of migraines. For those that are refractory to either NSAIDs or triptans, you want to start thinking about the DHE or combination. So you want to think about combining both a triptan with an anti-inflammatory. You might even also consider adding another anti-nausea medication to that combination as well. So certain dopamine agonists, and then certainly ergots. The thing to keep in mind with ergots and DHE is that they can actually cause nausea as a side effect. Contraindications to vasoconstricting drugs for those patients who have history of stroke or MI, then you want to use NSAIDs with caution. So then you want to consider using dopamine antagonists or some kind of combinations with caffeine. And then obviously combinations with tramadol as well are options. And now if they do have contraindications to vasoconstricting drugs, certainly the class of gepants are an option as well for acute treatment. So triptans, they were actually developed in the 1990s. And it's not really until now recently where we had these development of the gepants for acute treatment. So as I mentioned, these are the different triptans that are available on the market now. And there are varying durations of effectiveness for these different triptans. They're also available in different tablets or sublingual melts. They also have nasal sprays and they have inhaled powders. And there's, of course, there's a sub-Q injection with sumatriptan. So the onset can be, rapid for some and longer for others. And then the duration of the effect can also be shorter for some and then longer for others. So because naratriptan, frovatriptan, and zolmitriptan all have relatively longer duration, they are typically recommended for the menstrual migraines. So triptans, again, sort of these is now listed in the order of the half-life. So the shortest half-life to the longest half-life. And these triptans are selective agonists for serotonin 1B and serotonin 1D receptors. So those are things to think about because they are vasoconstrictors. And that's why there's a contraindication in using them for patients with MI or with strokes or with peripheral vascular disease. So those are the things to keep in mind. So the triptans, as I mentioned, are available as tablets, nasal sprays, injections, melts, and inhaled powders. The side effects typically that we see are flushing, hot sensations, paresthesias, chest pain, jaw tightness. Even though they may have some of those side effects with one of the triptans, they may not necessarily have the same side effects with the other triptans. So it's still worthwhile to try other triptans, even though they've had a side effect with one. You want to recommend that the triptans need to be used less than 10 days per month. And as I mentioned, they're contraindicated in certain diseases like cardiovascular, cerebrovascular, ischemic bowel disease. You don't want to combine them with ergot use because, again, they're both vasoconstrictors. So you don't want to be using DHE with the triptans within a 24-hour period. As I mentioned, the ergots have a side effect of the nausea and vomiting. So other things to use for acute migraine treatment, if there are contraindications, certainly dopamine antagonists, so chlorperazine, chlorpromazine, metoclopramide work very well, not only to treat the nausea that's associated with the migraines, but also the pain. Toradol, IM, or indomethacin are certainly stronger anti-inflammatories. Things like ketoprofen, diclofenac are prescription level NSAIDs that are also commonly used that work well and can have a longer duration of action. And then things to sort of break cycles. So when a patient comes in and has had, let's say, 3 days of migraines, they're not responding to their typical triptans, we do like to use steroids to try and break their cycle. And usually it's typically a taper. And that taper could be a Medrol pack, it could be prednisone, or it could be dexamethasone. Other things that we can do are nerve blocks, which are procedures that we do in the headache center, but certainly DHEIM is another possibility to treat and break a cycle. And in general, in headache medicine, we really avoid opioids or any kind of butalbital containing medications for acute treatment. So we don't use any opioids or any butalbital like Fioricet. So the guidelines are really, you want to ask about how frequently they're using their acute treatment. And we want to really avoid using triptans more than 10 days a month or any over-the-counter analgesics more than 15 days per month, because that can lead to what's called medication overuse headaches. So in general, you want to say, when I write a prescription for triptans or any acute medication, I will say on the prescription, no more than 2 to 3 days per week. So that's really important. You always want to consider, again, sort of cost for the patient, onset of action, the delivery, as we talked about. The fastest is the sub-Q version of sumatriptan. So for patients that wake up, whether it's in the middle of the night or in the morning with migraines, then you want to use the sumatriptan sub-Q because it's fast. It does tend to have probably more side effects, but for fast onset, that's the best way to go. And then in general, there tends to be a low risk of serotonin syndrome with these triptans. But again, for somebody who is on potentially other SNRIs or on other medications that could increase the level of serotonin, these are potential side effects that you may want to discuss with your patients. One of the newer medications, too, for acute treatment is called lasmiditan. The benefit is that it is also a serotonin, but it's a 1F receptor agonist, and it does not cause vasoconstriction. So again, this is something that's potentially safer in patients with cerebrovascular disease or cardiovascular disease. The main issue with the lasmiditan is that it does have a side effect of dizziness and somnolence and does carry it is a controlled substance as a result, and patients are advised not to drive for an 8-hour period after taking that medication, which obviously can have a big impact on function if you can't drive for 8 hours. So that's one of the limitations of lasmiditan. But it is a nice new novel medication that can be used for acute treatment. The other ones are called Gepants, and you guys have probably seen a lot of advertising for it now. Abrogepant, or also called Ubrelvy, Rimagepant, which is Nurtec. They were both approved in December of 2019 and February of 2020, respectively. The main contraindication is that they can't be administered with strong CYP3A4 inhibitors, both of them. The Rimagepant has an oral disintegrating formulation, which is supposed to be, again, sort of faster in onset of action. Both of them, what we've seen in practice are actually have very minimal side effects. And they'll know after trying it a few times whether or not it actually works. So they're definitely good options for acute treatment. So let's go back to Tina. And what we're having her do is actually keep a headache diary. So she combines now sumatriptan with an antiemetic. And instead of the 50, we're actually having her use 100 milligrams. Because if you remember, she was actually redosing fairly frequently. So instead of using the sumatriptan 50 up front, we have her use the 100. And because of her nausea, when we took her history, we combine it with an antiemetic. So when you ask her, she's now using sumatriptan 10 times per month, okay, which is a problem. So we want to really start thinking about migraine prevention for her now. So the goal of prevention is you want to reduce their attack frequency, severity, and duration, and really kind of limit their disability. You want to potentially improve their responsive to their acute treatment. And we've seen patients where when they're started on a daily preventive, they actually can respond better to their acute medications. You want to improve function, reduce disability, and then obviously reduce any sort of distress and psychological symptoms associated with having frequent migraines. So this is from the guideline that was published now many years ago in the American Academy of Neurology's Green Journal. And this shows basically it's the quality sort of standards and evidence base for migraine prevention. So this basically based on the level of evidence that has been published on the different trials that are done, classifies a lot of these daily preventives based on level A, B, C, or U. So as you can see here, and I'll go into more detail about it. So for level A, the two medications that we really commonly use is Depakote and topiramate for antiepileptics. And then there's the beta blockers, and then there's the triptans for Frova for menstrually related migraines. For level B, which is probably effective, we use amitriptyline and venlafaxine, and then atenolol and nadolol. And then for triptans, we use the naratriptan and zolmitriptan for menstrual migraines. So those are kind of the more common medications that we typically use. Obviously, there are caveats, like, for example, for Depakote, for women of childbearing age, which we commonly find have migraines, we wouldn't want to use Depakote because of the potential impact on the fetus. So those are things to keep in mind. Level C has possible efficacy, but again, we do use these fairly commonly. Candesartan, I would say has been more information published about that. And for the younger sort of young women, less than 18, typically cyproheptadine is a good medication to use. So one comment about medication overuse headache, which we commonly see, and again, we need to really ask about how frequently you're using the headaches. So do they have headaches greater than 15 days per month? And are they using the over-the-counter? So typically, we classify a patient with medication overuse headache when they're using triptans, ergots, opioids, or combination analgesics more than 10 times per month. If they're using any NSAIDs greater than 50 times per month, and again, this is typically greater than 3 months, we would classify them as having medication overuse headaches as well. So you always want to ask about how often they're using their acute treatments. And in general, whenever you're prescribing an acute treatment, you want to say limit to no more than 2 to 3 days per week. So we go back to Tina. So we educate her because she's actually using her triptans, or she's using her sumatriptan 10 times per month. So you educate her, okay, you need to really limit your use of that. And we say, look, you're probably going to benefit from starting a daily preventive with the goal of decreasing your migraine frequency and therefore not needing to use the sumatriptan so often. So here's the question. What medication would you like to choose? So things to think about, especially for patients who may not necessarily are willing to try prescription medications, you want to start thinking about behavioral treatments. So there is level A evidence for cognitive behavioral therapy, biofeedback, and relaxation training. We also a lot of times will use vitamin B2 and magnesium oxide. Coenzyme Q10 is another option too. So these are all potential, they all have roles in the treatment of migraine. Other treatment options too to think about other than medications and other behavioral treatments are Botox, so onabotulinum toxin A is FDA approved. And now this is specifically for chronic migraine, which means you have to fulfill the ICHD-3 classification for chronic migraine, meaning 15 or more headache days per month, with 8 of which have migrainous features. Typically, from an insurance standpoint, they need to have already failed 3 classes of preventive medications, meaning beta blockers or antihypertensives, antiepileptics, and maybe a tricyclic or an SNRI. These injections are given every 12 weeks, and typically it's 31 injections that's given each time. So this just gives you a picture of where the injection sites are when we do onabotulinum toxin A injections for chronic migraine. The other intervention that you can think about as a treatment option are peripheral nerve blocks. So there's occipital nerve blocks, there's supraorbital nerve blocks, and then the last picture there is also showing the trigeminal, the other trigeminal nerve block, the auriculotemporal nerve block. So when we think about it, it's really V1, V2, V3, and then the occipital C2, C3, where we basically, the nerve blocks, we use bupivacaine and we try to interfere with pain transmission and the pain pathway. The other class of treatments that you need to think about, again, this has sort of evolved over the last couple of years, is neuromodulation. So there are certain devices that are being used now. The Cephalid, you don't even need a prescription, and patients can get access to it, that will stimulate various nerves in different ways. So there's a transcutaneous supraorbital nerve stimulator, and I'll show you pictures of that. There's a vagal nerve stimulator. There's a transcranial magnetic stimulator called the MiniSpring TMS. And then there's also research that's being done on occipital nerve stimulation. So these are just some pictures that show you on the left-hand side here is a Cephally device, which stimulates a supraorbital nerve that you wear on the top of your head. And that can be used both for acute treatment and preventive treatment. The Mini Spring TMS is the one on the top right. And there are ones too that kind of go along with the neuromodulator is some kind of headache diary that they like you to keep to see how often you're using it. This is the vagal nerve stimulator. That's on the bottom left is the picture of the older Spring TMS. There's also a remote electrical neuromodulator that goes on your arm, and another one that goes kind of across the forehead that both stimulates both the occipital nerve and the trigeminal nerve. Again, sort of also goes with an app on your phone. So the newest class of medications that are really used for prevention are the CGRP antagonists. I'm not going to go into the physiology about it, but there are certainly a lot of evidence that has mounted over the last many years that CGRP is involved in migraine and can actually, when people have migraines, have high levels of CGRP in their system. So currently there are 4 FDA-approved CGRP monoclonal antibodies: arenimab, galcanezumab, fremanezumab, and eptinezumab, and they were kind of actually approved in that specific order that's listed there. The first 3 are actually sub-Q injections that the patients can actually do at home, and they're done on a monthly basis. And then the eptinezumab is actually an infusion that's done every 12 weeks. And typically they can be prescribed for both episodic and chronic migraine. So they don't necessarily have to have the diagnosis of chronic migraine, which is the 15 headache days per month, of which 8 have migrainous features. When insurance covers it, they typically have to have failed, again, similar to the onabotulinum toxin A, they typically have to have failed at least 2 or 3 other sort of oral daily preventives prior to starting these medications. In general, we've seen in practice, they have a very favorable side effect profile with minimal side effects. Typically what we've seen some constipation with the arenimab and then some injection site reactions with the others. The eptinezumab sometimes has some upper respiratory symptoms as side effects. But in general, they're very, very well tolerated relative to some of the other oral daily preventive medications that we have prescribed traditionally for migraine prevention. And this gives you a little bit more detail on the dosing, what the target is, receptor, the CGRP receptor versus the ligand, when they were approved, and then the various companies that have manufactured it and produced it. And one thing that I did want to sort of mention to you guys, which I think is a very important piece, is the costs of the CGRPs and just in general, the cost of medications for these drugs. So, topiramate, which again, we do use as an oral preventive, can typically cost about $75 per month. Metoprolol, has been around a lot longer, is costing about $16 per month. Amitriptyline, again, another older medication, $17 per month. The Cephally device is a one-time cost. That's about $500. And then you have the CGRP, which can cost a much more. So those are things to keep in mind. Obviously, you always want to be sensitive to the patients when it comes to cost. These are some resources that are available. I had gone over and I presented to you that the guidelines, that was published by the American Academy of Neurology in conjunction with the American Headache Society, which are the guidelines that were published in 2012. Those are always good to look up, and it has kind of the listing of the class A, level B, level C evidence for oral preventives. The American Headache Society is also another good resource, in addition to the National Headache Foundation and the ACHE. These are references. Again, the International Classification of Headache Disorders does have the actual definitions for both migraine, tension, chronic, episodic that are helpful. And then the American Headache Society published a great article on how do you integrate some of these new migraine treatments, meaning the CGRPs, into clinical practice that was published in 2019. So with that, we can move on to a question and answer period. And I will turn it over to Melissa to moderate that.
Thank you, Dr. Villanueva. That was really interesting, and I enjoyed the art that you chose as well. So far, we don't have any questions in the chat, so I'm just going to give a minute to participants to start typing up some of those questions that we have after the lecture today and see what we can come up with. Okay, First question, how quickly do the G-PANs tend to start working?
So for the G-PANs, which are used for acute treatment, they do tend to work fairly quickly. So I would say within probably 30 minutes to an hour, you should see some kind of effect. So which is somewhat similar to the triptans.
Okay, and the next question, can you switch from one G-PAN to the other?
Yes. So we've had patients try, ibrogepant, and then it doesn't work, and then actually get relief from rimagepant, and vice versa. Rimagepant, they've used rimagepant, and then they will switch to ibrogepant.
Okay.
That is not a problem at all.
So are these medications that can be prescribed and managed in primary care, or would you recommend a neuro referral before prescribing them?
Excellent question. I think in general, primary care, I think, has started to prescribe some of the CGRPs, the monthly injections. I think typically, because from an insurance standpoint, they typically require a fairly good history of failing certain classes of medications. We obviously feel comfortable doing that. And so you could certainly refer. I think it's reasonable to say that primary care could try some of the different classes of oral medications first. So in other words, primary care could recommend an antihypertensive, or an anti-epileptic, or an SNRI or tricyclic. And sometimes you might need a combination of two. You might not necessarily do one at a time before necessarily referring to us. I think primary care, though, does have the capability of prescribing these meds on their own and managing them. So I think that's certainly a possibility. I just haven't seen that many. And we have some general neurologists too, sometimes that even just refer to our headache center still, because they just don't have as much experience in prescribing these medications. But I think, it's reasonable for primary care to work through oral preventive medications first and then refer.
Okay, great. You may need to excuse my pronunciation with this one. Combination of ergotamine and lysine with another NSAID should not be associated for acute treatment, correct? How often should ergotamine be administered?
So I heard the ergotamine is, can I see
the second one was
okay, here I see it now. I see it.
Yeah.
I'm not sure what they meant with lysine. So the combination of ergotamine, I'm assuming with I'm not sure what lysine. Do you mean lysine? I'm not sure what you mean by lysine. Okay. Ergotamine is certainly can be used for acute treatment together with an NSAID.
So she commented below, it's an NSAID with ergotamine.
Oh, it's an NSAID with okay, yeah. So that should, yeah. So that can be. Oh, with another. So you want to add another anti-inflammatory to the lysine?
Migradorexine.
I'm not familiar with that medication, but the ergotamine in general, we would limit to no more than 2 days a week, I would say.
Okay, great. The next question, is the Cephally device recommended with meds?
Yes. So you can use the Cephally alone or in conjunction with medications. The Cephally can be helpful in certain conditions, like, for example, pregnancy, right? Where pregnant women may have some difficulty using medications because they are pregnant, then the Cephally can certainly be used. But the Cephally can be used in combination with different acute treatments and different preventive medications as well. So it can definitely be sort of a supplement, or it can be used alone if it works well. So that's a good question.
Okay, and the next one's about Cephally as well. How long has Cephally been approved? How often does the patient have to use?
So Cephally's probably been approved now for about 3 years. If you want to use it for acute treatment, then you use it basically for about a 20-minute. You use it kind of, actually depends on how the patient feels on it. For prevention, when you use it daily, you would use it typically for 20 minutes every single day. Then for acute treatment, it really is variable depending on how long the patient will need to kind of get acute relief. So when you're using it as needed, the length of time that we've seen patients use it can be variable. But if you want to use it for prevention, the recommended time is to use the device on your forehead for a 20-minute period every single day. And now the Cephally, and just going back to the Cephally for a second, the Cephally actually does not need a prescription any longer. So patient can actually access that by themselves without a prescription. So it does make it a little bit more accessible for patients.
Addictive potential of intranasal Stadol and how to incorporate it into a practice.
Yeah, we don't like using Stadol because it can be addictive. So in general, we just try to avoid that medication because anything that could potentially be addictive or be used too frequently, meaning more frequently than 2 or 3 days a week, we really avoid. So similar to things like butalbital or opioids, we don't like to use the Stadol nasal spray or otherwise because of the addiction potential. These are a lot of great questions.
Yes. And it looks like we've come to the end of the list of questions. So I'm just going to give a few moments to anyone that has any final questions before we start the Kahoot quiz. We have a follow-up from Karen. Why no butalbital?
Well, butalbital, because it has some addictive potential, and we've seen it a lot in the past. And actually, butalbital was prescribed much more frequently many years ago. We've seen it become addictive, and we've seen medication overuse headaches develop fairly frequently with that medication. And there can be a lot of withdrawal symptoms with patients who try to stop it abruptly. So in general, the butalbital specifically has to be tapered over a fairly long period of time. So mainly because of its addictive potential, we really avoid patients using that for acute treatment.
Okay, I think that concludes our question and answer period, and we will start the Kahoot quiz. Thanks again, Dr. Villanueva. I'm going to share my screen.
For having me, and thanks for some great questions.
And so hopefully everyone can see that. We are going to start the Kahoot quiz, and there are 2 ways to join. That's the way that we recommend it. It's really best played if you have it on 2 devices. So you can join at www.kahoot.it, and then the app. And then if you have it on your computer and you also have it on your phone while you're playing, that's probably the easiest way. So as players start to join, I'll just give folks a few minutes. Again, the game pin is right on the screen. It's 2740502. And as we wait for players to join, I would like to just remind everyone to complete the survey. When you close out of Zoom, we really aim to deliver content that everyone looks forward to, and it's curated by your feedback. Our next webinar topic coming up next month on September 14th is derm emergencies. And you'll find a list of all of our upcoming events at visualdx.com/events. So you can visit there for more details. We'll also be hitting the road again this fall in person, hopefully attending many of the top industry conferences, too many to name, but AAMP, HET, Health, ASAP, and Pri-Med, just to name a few. So we look forward to hopefully seeing some familiar faces at those. And it looks like we've got some players. I'll just give it a few more moments here for any final players to join. Again, it's a $100 Amazon gift card that the winner will receive. Okay, I'm going to get started. Congratulations, Mauricia. That was a very close game. Congrats. As the winner, you will get a $100 Amazon gift card. So congratulations. Thanks again, Dr. Villanueva, and for everyone that participated in the webinar this evening. We will share the recording with you and hope that you check us out next month for our Derm Emergencies webinar. Take care and have a great night.